morning. I'm going to go ahead and get started with this lecture today. This is a topic that's actually really exciting for me, so I hope that comes through in my lecture. I'm pretty sure it will. It's something I've been working on for a couple of years now, actually, and trying to connect it with Henry Ford, which is a possibility. It hasn't happened yet, but something we'll talk about too. There is time at the end of the lecture for questions if you have them, so please, and even throughout, if you have questions about who and what this is, let me know. This is a presentation I made actually just pretty much for the fellows. I've got a different presentation for the attendings on it for different reasons, because I think as I started to create this, I realized not everybody even knows what it is, what it does, what its capabilities are, and so that's what I'm going to present to you today. My name is Dr. Emily Hurst. I'm a fellow that graduated 2 years ago here from this program, and I'm currently an intensivist at Henry Ford West Bloomfield, for those of you who don't know who I am. Okay, so I do kind of have some disclosures because there is a little bit of confounding background for me for this. As I mentioned, I'm an intensivist I'm one of the night intensivists at Henry Ford West Bloomfield. I do work part-time for Avera EICU. I had that job before I actually started working at West Bloomfield, and because there's potential interest of doing EICU here, I've maintained that job so that if we do move forward with it here, that I've got those connections in the background and kind of know the workflow of that job. I have actually been listed as the interim medical director for a couple of months because our previous medical director had to take a transition for a little while. So it's kind of a weird role for me because I'm fairly new to all of this, but you'll see a video that I did because we were supposed to be doing some promotional things that I'm on as the medical director, which is just, again, like I said, strange because it's not a role that I necessarily feel like I'm all the way into just yet, but I've been acting as that. I am directly interested in Henry Ford having EICU if it's something that works out or is something that's adoptable, but I don't receive any financial reward from providing this lecture. So the objectives will be to explore and describe what EICU is and kind of how it works, provide some available evidence-based support for EICU services, and to discuss future consideration for EICU opportunities. So when I say why is this important to me, this is for you guys sitting in the chairs, why is this important to you as fellows primarily? Because in ICU in general, approximately 10% of all patients in the hospital are in the ICU. And it's 30% of our US healthcare costs though, so it's a tremendous burden on our economy. And part of it has to deal with cost reduction strategies that we need to think about. And this is something that hasn't been proven in that realm yet, but we'll talk about. So just in ICU in general, it's a big part of being in the ICU is what our healthcare dollars go towards. There were articles that came out early in the 2000s that estimated that around-the-clock intensivist managed ICU care could save more than 50,000 lives a year. So that's where some of that started coming. We started transitioning family practitioners and internists who were rounding in some smaller ICUs around the country to it being intensivist trained docs only. Now they're talking about how in the next 5 years, 50% of all patients will somehow be monitored remotely through either EICU services or some other services through their hospital that they may develop. The other part that I think is really important to know is some of you are going to stay in big tertiary care centers, some of you are going to go to smaller centers, and some of you are going to be in multitudes of types of centers. Half of all ICU patients nationwide are in small community centers or critical access hospitals. And so it's going to touch some of you one way or another, whether you're directly providing care to them or whether you're the doc requesting care from another site. So this is kind of a part of your future, whether you want it to be or not, just to clarify. So what is EICU? It's a remote electronic monitoring of patients in an intensive care unit. There's actually an intensivist, nursing staff, pharmacist, and secretary that are monitoring your patients, and they're doing that 24 hours a day. That's the staffing model for providing coverage for your patients. It is quite variable amongst the 20 plus companies in the United States that are doing this. So you can look at just about any of them, and they've all got a different model and idea of what it should be, which is part of why it's been difficult to collect data and research about its effectiveness, because everybody does it a little bit differently. The cool part is you can do almost anything at the bedside. So the only thing you don't have is a stethoscope, but actually they have the capacity to hook a stethoscope up to the monitors for you to listen to a patient 7 states away and to hear what their lung sounds and their heart tones and everything sounds like. We actually implemented that for a short period of time in the company that I work for, but we found that it really didn't change a whole lot of the information and management. It was very cost prohibitive because you had to have a monitor at each side of the bedside, and if you only had one for several beds, then they'd have to always find it, and it was an attachment, and so it just wasn't a very cost-effective way to monitor patients. So that part, although you can do it, is not a big part of my practice. You can't touch the patients. That's a big part. You can touch them by connecting with them visually, which I think is better than over the phone. But that's the physical part that lacks, but the rest of it you can pretty much do. The other thing right now that they don't typically allow, I don't have any hospital system that allows this at the moment, is to pronounce death. And it's interesting because you can do everything else, but you can't say that they're actually dead, even though you've got the monitor. You can hear if their chest, see if their chest is rising, talk to the nursing staff. Those are the things you cannot do. Really, too, what this is it's supposed to be collaboration with the bedside staff. So with your level of knowledge and your interaction with them, it's to be a supportive role to what they're doing already. It's not Big Brother. That's the biggest thing I try and get out of everybody's heads when I start talking to them about it, because they feel like somebody, well, it's a camera, and even with like Camtasia recording this today, it feels like, it puts a little bit of tension on people when they see a camera sitting over there. So if they do something at the bedside, that somebody's constantly watching them. That's not how it works. And that's not the intent ever of what EICU should be, or any telemonitoring health system. So what do I do when I'm sitting at the monitors? I'll show you a bigger picture of the one you're seeing down in the right-hand corner. But we do admits, so we don't actually do the full admit and write big admit notes and H&Ps, but we review an admit that's come in, especially one that's particularly complex, to make sure that there aren't things that haven't been seen or missed. Not such a big deal in big tertiary care centers. In the smaller centers, although big centers miss things too, smaller centers may not see that they had an anion gap, or they may not see that there was an acidosis they weren't paying attention to, or some lab value that makes sense to us as an intensivist that indicates something is going on with the patient. And so then our job is to communicate with them that there's something else going on here other than what they may have picked up on so far. We review and respond to every patient lab. So if they're abnormal, we help replace, refill, call to the bedside to see if something needs to be changed. So that sounds like a cumbersome job, but it's actually pretty quick because most of them are fine and you don't have to do anything with them. But it makes sure that every lab, if as soon as it pops up, I'm responding to. So there's sometimes it goes like 6 to 8 hours plus at the bedside that they're even aware that a lab came back because they're busy doing other things. So this is a instantaneous way to follow up on lab issues like a DKA patient or something else. We round in kind of cyclically on patients. So if there's not some of the other things that I'm going to talk about that we're doing, we can always round on a patient, kind of see what's going on. And they're called camera rounds. We go just literally hit the camera on the patient, look at them, see how they're doing, check their EMR, go to the next patient, and check all the ones that I'm in charge of monitoring for the day. I can review and write notes. I don't write daily progress notes in that fashion. Really, if I've got an intervention or something major I've done for the patient, I'll write up a little note so that the bedside doc can see what I did, or so that somebody after me can see what I was doing for that patient and they know what's going on. In critical access hospitals, and I'll explain that more if you don't know what a critical access hospital is, I actually do put a note in each day. It's an abbreviated note. It's not all the things you'd put in a normal note here. But some of the smaller sites really just don't know what to do with some basic stuff, and that's even changing antibiotics and things. So we give our basic recommendations of what we would do to support them at the bedside, and they can call us if they have questions. I read chest x-rays, EKGs. You can see them just as big as day as you can when you're at the bedside. I respond to e-alerts, which I'll show you here in a second. Monitor decompensating patients. So if there's a patient that is not doing well, or I've gotten several alerts that they're decompensating, I will pull up their entire telemonitor in front of me showing their SATs and their vital signs, their respiratory rate. And I can watch that right in front of me. I can put it up as the screen is standing right there. I adjust antibiotics to cultures. So if we get a bunch of cultures back stating that they're on the wrong antibiotic, we get, again, as soon as the culture comes positive, that's alerted to me, and I can change antibiotics to the bedside. We discuss problem cases with staff and physicians. That's one of my favorite things, actually, because that's when you do it on this level, it's one thing, I'm sure you get cases every day that you guys get to discuss that are complex with the patients you're dealing with, but because this is on such a bigger scale, there are people all over the place that have weird presentations of things, and so it makes me actually think through bigger problems that I probably get exposed to if I'm just in one location. So I enjoy that a lot, and working through the patients with the staff that are present, or even contacting some of my own consultants if I need to. You can alert the bedside staff of problems identified, which I kind of already went over. You can hold family meetings. Although you think that it might not be very personable and you can't touch to be on a big video screen in front of somebody and talk to them at 3 o'clock in the morning when there's nobody present in the hospital to have a discussion with them and their family members decompensating, being able to communicate with them and see them eye to eye, see see their emotions and how they're responding to what you're saying is actually very comforting to families, and we get responses all the time that they're very grateful for the conversations we may have had with them. I kind of did that as a duplicate. Collaborate on difficult and complex patients. You can connect staff to consultants, whether they're consultants that are going to be under you. If you've got some specific random endocrine problem or hem-onc issue or nephro problem that you may not be able to manage yourself, you can connect them directly to other consultants that are accepting of your service, which is really nice because sometimes you get some very strange things and you're just like, want to talk and collaborate with another doc on the team. We help facilitate transfers if the patient does have to transfer to a different type of care. Extubate all the time, whether they're medically ready or whether it's like post-op. So I'll have post-op cases come to the ICU and they'll stay there because they're complex. We'll extubate them if it's appropriate an hour later or 10 hours later the following day if it's not. And then they don't have to keep the patients in their PACU. We adjust vent settings and provide end-of-life care. We also provide bedside assistance for emergencies. Our response time is 30 seconds. So if there are literally buttons on the wall, it's like the easy button from Staples. It's a big red button. It says EICU on it. If there's a nurse or even a family member, or the patients don't typically push them, although I think we had that happen once, or a fellow or a resident or a doc, and you walk into the room and the patient's in distress and you don't know what to do or you just want backup, they will literally hit the button. I get an alert, I go camera into the room with the headset on and everything at my fingertips, and I start communicating with them. And if it's a code, I start managing the code. If it's an intubation, I contact the right person to get the intubation and start managing whatever the problem is in front of me. It's a 24-hour intensivist monitoring system and accessibility, so it doesn't matter what time of the night the nurse is distressed or the family practitioner or the internist or even another intensivist. If they need help or assistance or guidance, we're always available whenever they push the button. It also provides an extra set of eyes on patients, even if the intensivist is actively rounding. You'd be surprised how many times in a really big ICU, something major is going on and the intensivist is completely involved in that and another patient starts crashing. It doesn't have to be a code, but it does happen as well sometimes. You'll go and monitor the other patient. The nurse's staff will say, Dr. So-and-so is busy in room 210, can you please go manage 214? And those things happen all the time, but that's because that's the partnership collaborative model that we try really encourage and support. I talked about running codes. We can also supervise procedures. We've done that several times when people have struggled with putting in a line or doing an intubation or any number of various procedures. So this is the table that we sit at. The table goes up and down. It actually can go up as high as my chin, which would kind of be not useful. And it can go just about 2 feet off the ground. So really, whatever position you need to be in to be monitoring those desks so that you have the best accessibility for your body or ergonomics, you can adjust this table too. There's 8 monitor screens. That's the typical setup. There are some models that run off of 6 screens. There are some that run off of portable screens. There's all sorts of different models. This one I'm probably most familiar with, so that's why it's most comfortable to me, but that doesn't mean it's the best. On each of the different screens, and I can show you that too. This top one has something called orbs, and I've got that promotional video I showed you that I'll show you at the end, because what it does, not that I want to promote from that standpoint, but what it does is it shows you kind of actively what these different screens show me. So this is vital signs. So like this is a patient that we pulled up directly to monitor because something was going on. These are orbs. Like this orb has 3 big red circles in it, meaning that there's 3 major systems in that patient's body that are having high alert problems that you need to monitor closely or that you might want to investigate further. And then as the orbs clear, the patient's doing better, the orbs clear. This is the EMR, and I can see all of their labs, their I's and O's, their medications, their drips, anything you would want to in a normal EMR. And this system is directly linked to it. So even though our current program, we monitor 7 different EMRs, I'll pull it up and I can get probably 90% of any information I want to in this common EMR, which is very helpful. That's more vital signs. I always have the web up, and then this is an admit board, so it tells me which admits are coming in, how many I have. Chest x-rays, EKGs, things you can read. This is EMR, so I just click on the patient's name and pick who I want to touch base with. This is my screen of my current active patient lists. If I had to get into a patient's room, I would literally just click on, there's a little camera right to the left, click on it, put on my headset, and I'd be in the room. And then the screen comes up here, and there's a little camera sitting right here that then they can see me with. You can also see yourself on the camera, so you make sure you're not doing anything silly as you're communicating. And this is my e-alerts page. This shows me my vital signs and anything that are abnormal. And this is just a closer vision of, I can pull up a chest x-ray, make it the whole screen just like you would your normal PACS. And the same with EKGs. This is kind of a funny one because they had drawn specifically on it, but you could pull up your normal full screen EKGs. So there's some specific things we monitor, and this has to do based on what the hospital really needs. So a lot of them are quality initiatives. We always monitor the e-alerts. I'm always checking the labs, as I said. We also review the charts, and we have what's the word for it? It's a running scroll of the patients, and if they have 2 or more blood sugars greater than 200, then we'll look and make adjustments to their insulin to get their sugars under better control. There's GI and DVT prophylaxis, and since we initiated this 2 years ago, we've had 100% compliance with every patient on GI and DVT prophylaxis. We are now rolling out this month the 6-hour sepsis bundle follow-up. So actually CMS, we applied to CMS to see if we could do the 6-hour follow-up. They will let us do that recheck of the lactate, of their pulse, of their coloration, of their heart rate, and how they're perfusing. Document it in the chart. And so this is particularly helpful for small sites, actually big sites too, because if the doc gets a patient a septic 4 o'clock in the afternoon and they're out the door 6 hours later at 10 o'clock at night, they're not going to be at the bedside to do the follow-up note. Now fellows or residents may be doing that, but in smaller hospitals, if they don't have that type of support, we can do those notes for them. The ABCDE bundles are coming up. That's going to be happening here pretty soon. Those are also ones that are in development. There's about, I don't know, probably 5 or 6 different companies in the United States doing EICU that are looking into the ABCDE bundles. And we're trying to actually do it collaboratively. So I was on part of a conference call, a national conference call the other day, just discussing how we can start rolling that out. Nobody's doing that very well yet, and we know it. And then specific site requests. So if you're in a hospital system or a specific hospital and they have something that they would like for you to monitor, you can do that too as part of quality initiatives for them. You guys are familiar, just in case if you're not, but I'm pretty sure there's nobody here who wouldn't know what the ABCDE bundle is. Yeah. Okay. So I'm going to skip these. I am going to show you at the end just because it shows you a visual run through kind of where I work and what I do when I'm working for Avera. And so it also shows the collaboration of the work with the emergency department, which is actually pretty fascinating. I can see a patient that's come into the emergency department, what happened with them, that they decompensated, that they're sick enough to go to the ICU, and I get direct visualization, communication, information on that patient so that as soon as they roll into the ICU, we're rocking and rolling with everything that they need to have done for them for care. So why does all of this matter? Well, we're trying to prove that, for one thing. That's something that has not been a small task. But it does, when you look at the different challenges that are in healthcare, we're having staffing and workforce shortages. This does not replace a physician at the bedside, but it can give significant support. Some of our bigger centers that have had intensivists at the bedside have our support, and they can manage a lot more patients and a lot more sick patients when they've got somebody else to run into another room, literally, or camera into another room, however you want to look at that, at the same time as they're managing something else. So it's very beneficial in a really busy intensive care setting. There's some places that have geographic isolation. So anywhere in the United States, particularly for us in Michigan, the whole UP does not have access to care. They don't have an intensivist that's going to come to their bedside in some of those small hospitals, but they have ICU beds. So if they do have an intensivist that kind of comes and rounds and then leaves for the day, they're not there 24 hours a day, so they don't have that extra support. Patient care, limited access, kind of the same thing. Not having access to the same types of consultants and docs that might be available where you are. Poor performance on quality measures, just because you don't have the resources or are not aware of what's out there. So we help a lot with that. Aging population, having more patients that are getting older and sicker and having more modalities and things to treat them comes into play. Healthcare plan coverage is another issue. Financial sustainability and diminished community resources. There are hospitals that cannot afford to have an intensivist come to them. So if they don't have a service, they either lose those DRGs from those patients because they have to transfer them out, or their hospital shuts down. There are literally hospital systems we've gone into that we're going to shut down on multiple reasons because they didn't have the support and access they need. And we didn't just support them from EICU, we supported them with other things. But by having the access to people coming in and giving them what they needed, they were much better able to function and maintain. Reimbursements, capitated reimbursements, that's going to continue to come down the road. You guys are going to see that, every one of you as fellows in your practice. Expectations I threw in a little later because really at West Bloomfield there are all sorts of expectations that families have, and when they want something they want it right then and right there. That's not always appropriate, but that's what people are demanding, and some places are being able to meet it. This is something that provides a little bit of extra support from that, actually a lot, because literally you hit a button on the wall and you're there. They've got a doc at the bedside, whether it's a distress issue or just wanting to talk to somebody. Medical modalities, there are more of them, and having their accessibility to them is also changing. So how does this impact on care? So you talk about a tertiary care center or a quaternary care center, large academic medical centers with multiple ICUs. That's what Henry Ford, Maine is. That's what we are as a big center. So when I talk about things from here on out, I'm talking about this type of a size of center. Community care centers, so West Bloomfield, Henry Ford West Bloomfield is more of a community center level of care for patients. They have limited availability to specialists, but they still are a very functional hospital with lots of support and modalities. And then there's critical access hospitals. So for those of you who don't know what a critical access hospital, or if you've always lived kind of in a city or a big area, these are hospitals that literally have like one bed that's kind of a storage room that when somebody's really sick and they don't know what to do with them, they put, and that's their ICU. That's kind of what a critical access hospital is. And there are some that have 2 and 3 beds, and although that may sound trivial to you, when there's a snowstorm or when there's no ability to transport that patient, they're managing a really, really, really sick patient that's critical on several levels because that's the only place they have to put them. So critical access hospitals are actually some of the most interesting ones I get to interact with, because sometimes I walk into a huge mess that it takes a lot of time to manage, but you'll get like 6 nurses coming to help you because they all want to see, and I kind of enjoy that too, actually. So larger portions of Upper Michigan have some critical access hospitals, and then a lot of the smaller states that you can work in have those too. So when I talk about tertiary care center, I put this very futuristic picture of a tertiary care center that somebody was building, because this is all evolving. The way that we manage patients, the way that we connect to patients, and what we do with them continues to change every single day. So when you talk about having a tertiary care center, they're talking about increased patient safety. How do you manage more patients over a bigger geographical area or with more ICUs to manage with better care and safety? It's really difficult to do, but this is one way that's really supporting that effort. Extended guidance for trainees. So when you have a student or a fellow or a resident at the bedside and it's their first night on call, like I still remember my first night on call here. It was my first time in the hospital. I still don't even think I could get computer access the very first night. And I was managing all of the units on the first floor. It was terrifying. And so to have somebody that you can contact if you're really getting into trouble, or if you're, hopefully before you get into trouble, however that needs to happen, it's a really great support resource. We're actually working on developing a training program so that fellows can also do portions of this, and that's going to be hopefully implemented in the next year or two. Closer monitoring and evaluating of critical care changes. They're happening all the time. It doesn't matter if there's an intensivist at the bedside. If they're rounding on one side of the unit and something's happening on the other, it doesn't mean they stop everything they're doing because somebody starts having hypotension. They wouldn't necessarily be told about that depending on how the unit's structured. And so we come in and help and give that support at the bedside. It increases patient care and improves patient care by early identification of subtle negative changes. When you say that, I think it's hard to understand what that means. So a good example that I kind of come up with over time to try and explain it is when you, so say I just, I'm on overnight, like I always am anyway. Came in and I had a patient whose blood pressure was 136 over 74, no big deal, looks pretty good. I sign out, nothing's alarming, nothing's bad, their map's fine. And then all of a sudden it drops and they're 92 over 48. It's a drop of almost 40 points, probably is 40 points if I figure out the math. And that doesn't mean that somebody's going to necessarily know that that patient's decompensating, because it's not going to set up alarms. And if I just saw the patient and somebody else comes on board, they're not going to know that it's happening just by walking by the patient, nor would the nursing staff necessarily know that. So that's something that would actually alarm in my world, that somebody's having an acute change over a rapid period of time. And then we would investigate that. Is it a fluid bolus issue? Did they just get pain medication? Something else that's changing? Or are they clinically decompensating rapidly? The other part I like is the increased focus on quality metrics. You can pick out something that you specifically want to work on in your hospital system and improve it and make changes to it vastly, because you can actually monitor the time things are done. You can have alerts to remind yourself to check things on patients, and you can have people rounding on them and doing them actively every day. They work in conjunction with the bedside team, which is really our job no matter where we work. And you can do mobile supportive step-down beds. So even if it's not your ICU beds, there's some facilities, there's a lot of facilities that have very functional step-down units. Some hospitals don't have very functional step-down units. It's a way to actually get some of the burden off of your ICU into your step-down units with patients that are a little sicker there because they still have support, and we can still monitor them there as well. Physician support and rapid responses, as I already told you. It actually decreases burnout because the staff has reduced calls. There's reduced coverage that they have to provide at different times. It can use gap coverage. It can also support financial stability in the hospital by increasing their service offerings and what they're able to bill for in the near future, maintain more patients, and support community economy. When you go to a smaller center, a community care center, and this is a newer community center, but again, they're all kind of, the old little ones are getting torn down and they're building bigger, fancier ones. It helps them support their financial stability because they can also increase their service offerings. They can have access to unavailable specialists. They can maintain more patients, and it supports their community economy as well. It's a key resource center. It helps them be a key resource center for a region if it's in a small area. It can improve their care throughout the state, solidify supervising hospitals' reputation and connection with them, and then serves the community with the patients that go there. The other thing with a community rural care center is you've got rural workforce support. You have access to professional colleagues, which is another thing. I've actually established relationships with all sorts of docs that I've worked with over the cameras, and we see them, and I know that they've been on maternity leave, or one just came back because they had a surgery or whatever, and we connect just like we do when we're walking in the halls. It's kind of surprising to me. I didn't think that I would connect to these rural hospitals and the docs that work there as much as I do some of the colleagues I work with every day. It extends your physician's practice, so I get exposure to things in different areas of the country that are rampant in those areas that aren't some other places. So like for us, here we see more tuberculosis. There's other places that see more HIV and other types of infections that we don't get exposure to. So it's kind of nice for me to be refreshed on those things and have, I think, a bigger background in the things that I can treat. Well, you can treat anything, obviously, but better exposure to it so I'm more familiar with it because I see it more often. Supports their financial stability because, again, they can maintain more patients and support their community economy, which I've said several times. So the part for me that's really cool, too, about EICU, it's really endless options. There are so many things it can extend into. So right now, the current company I'm working with has EICU. They have e-pharmacy. They're branching into e-palliative care. They just started e-behavioral health. They also do e-pharmacy and e-emergency and e-long-term care. So those are ways to connect all of those facilities and all of those people who don't have access to care. And as a larger center, if it is something that ends up coming to Henry Ford, it's super exciting here too because we already connect and support people all over the world, not just in Michigan, not just in Detroit, not just in the Midwest. We can give follow-up pulmonology consults to people who fly here from all over the world to have procedures done, either through IP, through transplant, through pulmonary, through cardiology, and we can provide follow-up consults to them throughout life for them. Even though they came here for their procedure, they may be able to go then on to something else, which is pretty cool. The other aspect of it is educational. So we have a sim center, so we could have people come in from all over the place that we could teach procedures to so that they can take it back to their hospitals. You can also do e-lectures and conferences. When you connect over the internet, there's usually a big, I lecture over all sorts of states now, I think 11 states. So I'll stand at a podium just like this, and in front of me will be a big screen like this, and there'll be quadrants. There'll be about 9 to 12 quadrants, and each one of those are the sites. So I can actually see the people sitting there. I can see them raising their hand. They can stand up to a podium and ask questions, and you can actually give a live lecture just like I am now. It takes a little bit of getting used to, but it's neat, and they get to see people and have access to people they wouldn't normally get lectures from. So it's also nice for educational purposes of your residents. When you talk about potential return, it's a more efficient use of ICU beds. You can standardize care better. You can be involved with QI activities, and it doesn't have to be just the ICU. It can be any of your e-care services. You can use Apache data utilization, decrease length of stay and mortality, grow your referral business, increase your surgical and interventional programs, and just perform outreach as a commitment to your community. It can also decrease costs for outcome measures, help with cost efficiency and bundled payments, support financial stability by increasing your service offerings and maintaining your patients, and being a key resource center. I think if they do bring it here to Henry Ford, we will be a key resource center for not only the state, but beyond, way beyond. It takes us outside of the physical construct of what our building is, and we can't add any, I mean, we are obviously adding a big, huge cancer center, so we can add, and there's some areas we can tear down a couple blocks and add a little bit more, but there's still limitations to that. This takes us way beyond the capacity to do that without the same having to build a physical construct or another building in this area to maintain more patients. It just solidifies the reputation of the hospital that's connecting, assuming they're providing good care, obviously, and again, serving the community. So I have some case presentations. These are all actual cases, not the actual pictures, of things that I've come across. And I can literally come up with 100 things a day of things that I do, that I connect with, and things that I see that I wouldn't normally have access to. So this was one of my most exciting ones, and I think probably one of my most rewarding ones. I had a 54-year-old female who was in acute respiratory failure. She was actually quite a bit larger than this picture, but this was the biggest picture I could find on the internet of a large woman who looked like they needed to be intubated. She was in a community hospital out in the middle of nowhere. I'll tell you where it was, Wyoming, actually. And the closest hospital to them was 4 hours away, and that was via flight. She got admitted for pneumonia. She was decompensating. They had put her on a Veni mask, and that's pretty much what she looked like when I came into the room. I had him check an ABG, though, and her PO2 was 34. Her SATs were in the 70s, and they had been for some time. They did have a hospitalist. It was his first night on. He did attempt to intubate, but had no clue what he was doing and was very nervous. Plus, she was incredibly difficult because she was so morbidly obese, which just made it all more complex. I talked to him very calmly, and I said, hey, would you try it again if we walk through it? And he literally kind of stood in the corner and shook. He was done. And there was nobody else. This was not a hospital that had 24-hour anesthesia or anybody else who could come in and provide that service. So I talked to the nursing staff because we were losing ground quickly, and I said, do you guys have a paramedic service in this town? Because I didn't know how big it was. And I called a paramedic in off the street. His name was John. I still remember. And I said, John, have you intubated before? And he had. I put him at the head of the bed. I said, this is a very different case. If you've intubated before, you know what things look like. But we're going to ramp her, and I described all that to him. And he didn't get it on the first try. We didn't get it on the second. But on the third try, we got it. And this woman wouldn't have survived if John hadn't come in off the street from the ambulance service, because there was nothing else. I know the hospitalist, there was no way that was happening. He wouldn't even touch the scope. He was so fearful. And so fixed wing, there's an airplane, so she could be flown to Colorado to get care, and that's where she went. But that was 2 hours out. So if we hadn't intubated her, there's no way she would have survived with her oxygen saturations as low as they were by the time they arrived, and then to fly back to get support. So that was a pretty cool case. That's one of my favorite ones. I have another one. I had a 38-year-old male in a critical access hospital. He was in fulminant septic shock, sick as could be. The hospital did not want to keep him there. Typically, once they get intubated, they transfer them out. He had been intubated appropriately. He'd gotten his triple lumen catheters, but they had a horrible winter storm. So the fixed wing, meaning fixed wing airplane, their helicopter was down, and we couldn't even drive him via ambulance if he was even stable enough to do so, because it was so bad outside. They had like 14 inches of snow. So we couldn't get transferred. So I started ordering antibiotics and treating him for sepsis. The pharmacist could not get to the hospital to mix the antibiotics in their pharmacy. So I didn't even have that availability. So getting this guy here, I had, as I mentioned before, when you get a little critical access hospital, you'll get the nurses all come in. They are amazing. You'd be surprised at what some of these little critical access or community hospitals have for their resources. They'll come in, the nurses want to learn, they're very helpful, they're responsive, and this guy did just great. He did fine. We stabilized him throughout the night, and we actually got to fly him out the next morning. But these are some of those cases that in the smaller sites that I really enjoy. Makes me think on my feet, and it's fun. This is a kind of example for me, though, that happened. This was in a tertiary care center. This was a woman who came in, 46-year-old female, who came in with an intentional overdose of Klonopin. She was sleepy, as you would expect. She was bradycardic in the 50s, and she had a blood pressure of 74/37. They had given her boluses and hydrocortisone and tried to stimulate her, did all the things to try and treat her blood pressure, and it wasn't coming up. And so when I talked to them, I said, well, what else did she take? And I was, nope, nothing. She took Klonopin, that's it. We have the bottles, whatever. So the intensivist was done with it. They had to actually go on because they'd spent quite a bit of time with this woman trying to get her pressures up. She wasn't perfusing well. Her urine output had dropped, all of those things. I actually was able to go talk to the family and have them go to the house and discuss further with them. She had actually taken some beta blocker in addition, which they didn't know about. And I gave her some, actually before we even got that far, I gave her some glucagon and pressures came right up. But again, it's something that in a busy ICU, even though this seems very simple, the doc there was stressed, and we had talked about it, and we couldn't come up with a solution. And I got to spend more time sitting at it because she was decompensating, and they had to go on to take care of other things. So that was a good case too. The other thing that happens is you'll have, this is an 88-year-old gentleman. He wasn't that far actually from our main hospital, but he had end-stage renal disease. He'd had a major MI with STEMI, and he needed further support. He actually could have had great support at a heart hospital that was not that far from him, but they could not do the procedures he needed in the hospital he was in. He had never left the borders of his town, and he decided that he was going to refuse treatment. And so everybody was up in arms in the hospital about this because they said, you have to go, you have to get the treatment. And the part that I like about this is that if that gentleman wanted to stay in his community, we treated him medically. He did stay in his community, explaining to the staff who was very upset about it, and even the heart hospital that was supposed to accept him. The cardiologist was just like, this is ridiculous. He shouldn't be making this decision. I got to kind of mitigate kind of the situation that was there. He stayed. He did fine. He actually survived. I don't know how long or how well he did after that because he'd had a STEMI, but I get to play around with kind of giving support to the families emotionally too, which I think really helps sometimes, being that intermediate person when they don't have another person to do so. This one was really tough. I actually just had this one 2 nights ago. This was a 31-year-old male. He had been drinking. He got in a motor vehicle accident. He had a subdural and had a pretty bad accident, as I said, and had an anoxic brain injury. And he had been in the ICU for quite a few weeks because everything else was healthy on him. He just had an anoxic injury, and the family just couldn't let go. And so they've been waiting and waiting and waiting for this to happen. The intensivist literally had just entered another room to discuss something. It was a major transplant patient that they were discussing other things with. And the family decided right then and there, that's when they wanted to take the tube out, and that's when they were going to make it. And if they couldn't do it then, it was just like they weren't moving on. So it was really weird background and circumstances, but the intensivist was occupied, so I went into the room, I came over the camera, I talked to them, we did withdrawal of care, and the patient passed comfortably, instead of it being something else that just continued to go on and on. So there's lots of little circumstances where that helps. The other thing is if something else critical had happened with that patient, I could also go in and support them while they were out in the other room. So. There are supportive articles. I have actually explanations for several of them. These are ones that we put out in a publication. Well, we didn't publish it, but we put it out in something we were presenting to Henry Ford for consideration of it. I actually have it with me if anybody wants to see and read. I didn't have enough time to probably go over all of those with what I'm doing now. And the issue with most of them is that a lot of them are in community hospital settings where there has been proven benefit by support. But it's the large tertiary care centers that it's been difficult to provide support for yet because everybody manages them in a different way. So the outcomes from some of the smaller sites that they have resource data on is that it's severity adjusted, 20% reduction in mortality, 30% reductions in length of stay with associated decreased costs, greater discharges home instead of to a long-term care, better practice compliance and improved sepsis care, and decreased ventilator days. But extending that to large tertiary care centers has continued to prove kind of elusive. There's been various articles that have come out. Some of them have been equivocal, some of them have been negative, some of them have been positive. And at the end of the day, I don't really think it's given us a good answer as to what that means going into a big center, which is also why I'm sure it hasn't progressed as far as I would hoped it had here at Henry Ford. So what I can really speak to, at least in the small centers, what they've got supportive evidence of. The top clinical impacts that we have thus far is that it reduces mortality. It reduces ICU and hospital length of stay, improves the use of evidence-based medicine, and reduces complications. So in our hospital, the Apache data shows that it's decreased the mortality. So the black line is the expected mortality based on the Apache scores that they were given, and the tertiary care facilities are green, and then the EICU systems are purple. So they're all lower than, with the extra support, than the expected mortality by having the support of EICU. Length of stays are the same thing. The tertiary care facilities, the EICU support, are less than the expected length of stay based on the Apache data. It's been consistently, too, just of interest, it's been consistently 80% more or longer reduced than predicted. As I think, well, I know I mentioned earlier, GI and DVT prophylaxis have both gone up to 100% compliance, and they've maintained that now for almost 2 years. And also when you talk about complication reduction, one of the major ones they've done are ventilator days. So people aren't getting, if they don't have enough access to specialists and they don't have enough access to their intensivist, or their intensivist can only extubate when they're there for the first 2 hours of the day, and then they go off to do other things, or they go to clinic because they just have a pulmonologist in their town. People weren't getting extubated. So by having the EICU support post-operatively and then both medically, I extubate at least 1 or 2 people a shift, I'm sure. So it's getting them off the vents faster and more efficiently. So we can extubate 24 hours a day because we can monitor them as soon as it's been done. And so again, you've got your average vent days, tertiary care center, predicted days, and then how many days they were actually intubated. So really, there's got to be more research with this process. More data is coming out regularly about the benefits of EICU care, but we're going to have large multi-center papers evaluating the cost effectiveness. That's truly lacking at this point. There is more that's going to be coming out. Even at the end of this month, there's a big center that's putting out a presentation April 30th. So that'll be interesting to see. There's also significant variability in practice habits. So depending on what kind of support you have, it's hard to compare centers when they do it differently. And they all do it a little differently. Some have a much more collaborative model, some are much less. Having an EICU expansion and leading to data reports is also going to help. It's going to provide more supported value and more data-rich studies. So that's all stuff that's going to have to keep coming down the pipe for us to get further support. At the end of the day, just in summary, really what it is to provide assistance at the bedside for vital signs, electrolytes. It's your on-demand partner. Finding fluid boluses, nursing support, procedures, codes, family meetings. And the last thing I wanted to touch on was really, as fellows, things to consider. This is probably going to be a part, if you go to a large center, something you're going to be asked. They'll ask if you have any experience with it, if you're willing to do it. Some places are demanding that if you take a role with them, that you will be providing EICU support. So being aware of what it is and what it does. You have to really ask, because just because this is what I presented, this is what the company I'm working with does, that doesn't mean that all of them act in the same way. So it's crucial for you to ask specifically what they expect you to do and what kind of support and monitoring they'll do and how frequently. I don't ever recommend doing it full time. It should be an adjunctive part of your job, especially as new grads. If you go out and do this full time, you lose your connection to the bedside and having your direct patient care. And then as you age through your career, it's better to not lose focus of what it takes and what it's like to take care of the patients yourselves versus kind of telling people over camera what to do and how to manage that. So I would just always recommend that. And then, again, finding out what expectations they have. Exercise options and breaks. I had no idea how important that was going to be until I did more shifts than I had wanted to do for a little while they were short. It's not easy to sit for 12 hours in a shift all day. So I've actually implemented walking treadmills, basically, that go under your desk. They don't go faster than 2 miles per hour, but you can walk constantly and get your steps in while you're working. The people on the camera don't even realize you're doing it, and if you need to pause it, you can. And I'm working on some other chairs and things that you can do, so sitting on like yoga balls and some other things so that you're keeping yourself active. That's another important aspect, actually, if this is a job that you consider doing. If you do have interest in it and you look into it, it does increase your marketability of going to larger tertiary care centers. It may also, as you go to a smaller site, provide you with access to care and support from consultants that you didn't have otherwise. And to give you a break, one of the big things it's doing for some is that when they go to a smaller site, they actually have support overnight so they don't have to take calls. And it's another thing they use to lure you to a rural site. So it's going to come up. So it may affect I say may affect, it's probably going to affect your practice one way or another, whether you do it, whether it's support for you, or whether you're exposed to it in the near future. So I have references, my images, and then questions. And then I also want to show you real quick that, yeah, thanks.